that. And we need to work towards equal access. This is one of the principles at the core of the European Health Union. And this has a big impact on the topic that we are discussing today. We had about 17,000 new HIV infections in the EU, Iceland, Liechtenstein, and Norway in 2021, and about 1,900 people were diagnosed with AIDS. And this shows that there is still a great deal of work to do, especially because HIV, we know, often affects population groups which are already in the area of health more vulnerable. They're in a more vulnerable situations. There can be migrants, there can be men who have sex with men, there can be people who are injecting drugs. But this is not only. We mustn't only be looking at those vulnerable groups, but we do see a higher number in the past in the vulnerable groups. But this is also something that is changing. So we need to understand the stigma and the discrimination of those living with HIV, especially in health, including in healthcare settings. And this has been a priority of the Spanish presidency of the Council of the European Union, and one that I fully support. Because the fear of stigma, it's not only the stigma, just the fear of stigma can prevent people from going to be tested. The fear of stigma may mean that people miss opportunities for treatment and care, and that they may unknowingly transmit the virus to others. So it's so important for us all to keep raising awareness and speak about fighting stigma and the quality of life. And it's also a matter of halting the epidemic itself. And if I may just take a second away from my notes, I know that there are people here today who are living with HIV for many, many years. And I just wanted to say that I have the utmost respect, because I know that what they're facing, what they're dealing with today is nothing in relation to what they had to face 10, 20, 30, 40 years ago. And I think that we sometimes need to remind ourselves of this, because sometimes we take for granted where we are today, but it was not always like this. And there are people here, and I think that it's those people that we should be really thanking, who stood up in very difficult times and made sure that we reached a place where today we can talk about moving ahead, about quality of life, about better outcomes. And these are the people that really that I personally have a huge amount of respect for. And saying this, and I think it was mentioned also by our moderator, we need to ensure that HIV remains a priority in Europe. And we need to ensure that we keep this high on the political agenda. It's very easy for this to fall off the political agenda. We have self-assessment tools which measure the health-related quality of life, because we need to look at this issue in a multi-dimensional way. And we need to address the challenges that people living long-term with this disease are important. To do this, we're working with WHO, we're working with the EU member states to reach the target of the Sustainable Development Goals on the action to end the epidemic of HIV/AIDS and other communicable diseases by 2030. We have a public health expert group which brings together experts from EU member states, Norway and Iceland, to advise us and transfer the best practices on communicable diseases. And for the first time, we put forward in June, as a pillar of the European Health Union, our first comprehensive approach to mental health, which is also now a priority. And I want to thank everyone for their contributions to this. I'm going to end here, thanking you once again, and just wanted to assure you that this will remain very high on our agenda, because we need to work together. We need to be aware of what we all need to do in order to be able to move forward. And if I may just touch on one aspect of the European Health Union that I think is of very important interest to you. It's one of the pillars is the new pharmaceutical reform. We have put forward a new pharmaceutical reform after 19 years, which is looking to ensure, I call it the 3 A's, access, affordability, and availability of medicines for all patients in the EU, irrespective of where they live. And this includes innovative medicines, because innovation is only crucial if innovation reaches patients. And if we were able with COVID-19 to have a European vaccine strategy where every single citizen in the EU had access to a vaccine, whether they lived in a big or small member state, it didn't matter, at the same day, at the same time. This shouldn't only be possible at a time of crisis. And we need to work towards this, because that is our responsibility, to ensure that we have equity in access to medicines, in access to treatment of care for all citizens and all patients, no matter where they live in the EU. And of course, those living with HIV are a central part of this. So once again, thank you for the invitation. I apologize for having to leave immediately, but I'm told that where I am going is over 1 hour away by car. It's an event in relation to another pillar of the European Health Union, which is Europe's Beating Cancer Plan. But I did not want to not be here today. I wanted to be here in person. Thank you so much.
Thank you very much indeed, Commissioner. And your personal commitment and passion for taking action to address this issue is very much appreciated. And as you say, one of the focuses we need to discuss today is how to keep it on the agenda, how to keep it up. Very struck by what you said about the risk of it falling off. We will discuss that. We will tackle many of the questions that you raised about how to address those long-term needs. Thank you so much. Thank you very much indeed. So as the Commissioner leaves us, second Commissioner, the EU's Equality Commissioner, Helena Dalli, couldn't be with us today, but she did want to address you, and she sent us this short video message. So let's hear what she has to say.
Esteemed guests, dear colleagues, dear friends, I thank HIV Outcomes for organizing this event and the European Parliament for hosting it. HIV can now be regarded as a chronic disease thanks to continuing medical advances and prevention measures. But it is unacceptable that people living with HIV are still experiencing stigma in various walks of life, including when they seek healthcare. I welcome, therefore, the Spanish presidency prioritization of the fight against stigma and discrimination, which are hampering our HIV response and the well-being of persons living with HIV. It is stigma, or the fear of stigma, that can prevent people from getting tested, making it harder to mitigate the epidemic's impacts. The EU, its member states and partners are actively working on various fronts to combat HIV/AIDS and the associated stigma. The European Commission supports EU member states in reaching the global objective under Target 3.3 of the United Nations Sustainable Development Goals, which aims, among others, to end the AIDS epidemic by 2030. The EU is committed to playing its role in this important endeavor. The European Centre for Disease Prevention and Control provides guidance to countries on issues like pre-exposure prophylaxis and harm reduction strategies for people who inject drugs. The Commission facilitates the work of stakeholders through the Health Policy Platform. One of the platform's thematic networks recently issued a joint statement to address the stigma that people living with HIV experienced. The Commission has also set up a public health expert group, which can take steps to address stigma against people living with HIV. These steps could include targeted calls on our best practice portal. Recent data from the European Centre for Disease Prevention and Control clearly show that Europe must do much more to reach the HIV/AIDS-related SDGs, including the targets set by UN AIDS for 2025. The data underscores the importance of targeted education, awareness, and intervention efforts to combat stigma, especially for marginalized groups. In this regard, we must give special attention to LGBTIQ equality mainstreaming in health initiatives for HIV/AIDS prevention. The Commission's LGBTIQ equality strategy highlights this point. Today's conference is an opportunity for us to put together bold plans for ending the stigma and discrimination that people living with HIV still have to endure. I thank you for your support on this and look forward to hearing the outcome of your discussions.
So, Commissioner Dalli there, very much focusing on a central issue that we will discuss today. She called for bold plans to tackle stigma and discrimination. What do those plans need to look like? What is the sort of bold action that we need to take to build on efforts today? We're going to come back to that later on, but one of the points that Commissioner Kyriakides underlined very forcefully was the issue of addressing inequalities. And we're going to focus on that issue now. In our first intervention, we're moving into sort of context-setting presentation time, raising in more detail some of the issues we want to explore together. So to talk about shedding light on inequalities in ending HIV in Europe, Christine Stegling, who is the UNAIDS Deputy Executive Director, Policy, Advocacy and Knowledge Branch, again, could not be with us, but she very much wanted to talk to you. So she also pre-recorded her message. Let's hear what she had to say. We seem to have lost that video for now. So what I'm going to do, I'm going to move on, and hopefully we will be able to come back to it after our next intervention. So forgiving me for catching you slightly on the hop, I hope I don't. Let me welcome Magdalena Bartnik, European AIDS Treatment Group member and Executive Director of the Precursor Foundation for Social Policy in Poland, who's going to talk to us about accelerating HIV prevention for achieving the elimination targets. A very warm welcome to you, Magdalena. Thank you for jumping in. Magdalena is going to make some brief opening remarks, and then I have a couple of questions for her. Over to you.
Thank you very much. My name is Magdalena Bartnik, and it's an honor for me to take part in this significant event. I'm a member of European AIDS Treatment Group, and I also represent Precursor Foundation, a leading harm reduction organization based in Warsaw, offering comprehensive support for people who use drugs. We are working on the front line, operating low-threshold services, engaging with people and providing direct, non-judgmental, unconditional support for them. Precursor initiated progressive by Polish standards, interventions and projects, peer work, drug testing, drug consumption site. We are the originator and leader of the take-home naloxone pilot project, which is planned to begin next year. Non-governmental organizations in Poland make an enormous effort carrying the burden of responsibility for the health of citizens, while governmental institutions show their inaction, their lack of commitment, or even undermine the organizations' activities. This has been happening for the last eight years, and when representatives of Ministry of Health agencies indicate that they cannot do more due to low funding, regulations, or dependence on ministry, which by the way has censored prevention materials, it is organizations and activists doing everything to overcome these barriers. But we operate within this functional system. When we try to transcend its rigid framework, we are then pushed back into the cogs of the model. HIV response mechanism, hardened and obsolete, needs reform, or rather has to be built from the ground up on the new foundations and assumptions appropriate for current times. And the question must be stated whether civil society and government actually go hand in hand in efforts to reduce HIV and improve the lives of people, or whether it is rather NGOs that make persistent efforts to be able to implement effective strategies against passivity and reluctance of the government. And the key issues in this context: sexual minority rights, LGBTQ rights, women's rights, harmful gender norms, attitudes towards sex work, the authority of Catholic Church cannot be overlooked here. Lack of political will and vision, political cowardice reinforce the taboo around HIV. The fact is that this has been the case so far for practically all political options in Poland. We do hope that in a newly appointed government, there will be politicians with the sense of duty and responsibility, understanding that cooperation with civil society is essential. But again, are there mechanisms in the European Union to oblige national governments to fulfill the commitment towards ending HIV by 2030? I can easily imagine strong declarations which are not followed by anything. We can't end HIV unless we end the war on drugs. People who use drugs, particularly those who inject, face heightened stigma and discrimination. Criminalization of drug use and drug possession is a major impediment to the realization of the rights to health and causes human rights violations. It prevents people from accessing life-saving care and creates a legal basis for human rights abuses by law enforcement. Restrictive drug law introduced in Poland over 20 years ago, resulting in a gradual reduction in the number of clients of harm reduction programs, as well as the number of programs themselves by 2/3. Harm reduction is under-resourced, underfunded and under-supported, and it operates on the periphery of the health system instead of being a core element of a public health response to HIV. When discussing the acceleration of HIV prevention among people who inject drugs, we need to embed it in broader contexts: homelessness, loneliness, poverty, violence, access to mental health, access to primary health and social services for Polish citizens, but also for immigrants without legal status in the country, access to opioid agonist treatment, which is very low in Poland. Once I entered the treatment and caught my breath, I then started to think and care for my health. The sentence from one of our clients reflects well the dramatic situation in which many people find themselves. If you're homeless, experiencing violence, don't have access to treatment, just try to survive. You don't need any more bad news. What is urgently needed is a reform of drug policy, scaling up harm reduction services nationwide and making them available, accessible and acceptable to people who use drugs. This also applies to healthcare and social services. We need to support and empower community-led programs. At the heart of it all, combating stigma and discrimination, changing the narrative about drugs and drug use. Achieving the elimination targets requires broad cooperation between policymakers and governments, healthcare providers, harm reduction services, researchers, media representatives, pharmaceutical industry, and affected communities. Organizations cannot be left on their own, operating in a hostile environment and unable to count on institutional support, trying as hard as they can to protect the health and lives of those who are most vulnerable. Thank you.
Thank you very much indeed, Magdalena. And just to pick up on that point you made about all the people who need to be involved. As you say, you cannot do it alone. And you talked about the challenge you face at the moment with you driving the progress in this area and governments, as you put it, either not acting, lacking commitment, or even undermining you. What for you is the key to turning that round, to building the sorts of partnerships that will really help to address these issues? And just a thought, can the EU help at all in this respect?
Absolutely. EU can help, and also our efforts to make a pressure on government. You know, we are now changing the government. So after the elections month ago, the government changed, and we do hope that then we can find people to talk with and to discuss these issues, because since I remember that there wasn't really a possibility or space to have this discussion and to prioritize these issues in, with the politicians. So our efforts together, which is NGOs, but also many other stakeholders together, then we can just put a pressure on our government and talk with them and show that this issue is crucial.
And the EU, of course, can help with funding. Funding is a crucial issue. You mentioned the issue of funding. In what other areas? You're in the European Parliament. We have politicians here who, and we heard from the Commissioner, who said we have to keep this as a priority. What do you want from them to help you at the national level meet some of these really difficult challenges you're facing?
Yeah, my question from the statement I made was whether European Union can really have an impact or oblige national governments to follow, the regulations and plans. And I'm not quite sure if it is possible. What is needed most from our perspective is the pressure for civil society organizations together with other stakeholders who want to be allies in this, and then to put this pressure on politicians and confront them with all these questions, issues that haven't been raised before.
Indeed. So the challenge of the EU's limited powers in this area, limited competences, all it can do is exhort, encourage, but also provide some funding. Just coming back to your point about the most vulnerable groups, because you talked about them and you said we mustn't focus exclusively on them, but it needs to be a big part of the focus. What do you feel is the real key to fostering that understanding of the public of their own role in prevention and reaching these particular groups? I mean, is it using those multipliers that you talked about? How do you go about reaching the most difficult to reach?
I think when you look at the social awareness or consciousness about HIV in general, it seems that not much happened. And when you look at it, it seems like we are really stuck in 90s, as if we didn't really have this educational process among society to understand what HIV is and the consequences of not really taking care of it, not being, part of the public discussion. So first of all, the awareness among society that needs to be there, but also, of course, stigma and discrimination. Once we broaden our actions and harm reduction services, this can also lead to having stigma and discrimination not so, on their lives, present on their lives. So it works both ways. If we really accelerate the access to harm reduction and then change or reform the system, the care system, but also access to social services, then at the same time, this can play a role in combating stigma and discrimination, because once you are not visible and once there's no data around about vulnerable groups, it's treated as if it's not there, it's not present.
Absolutely. A very final question, and it's a question I'm going to be asking all our speakers this afternoon. The Commissioner talked about the importance of maintaining that political focus, albeit not in your country, but across Europe and at EU level, we have that. How do we maintain it? For you, what is the top priority for action, the sort of key next step we need to take if we are to really put more impetus and take advantage of this moment in the electoral cycle to raise this issue at this level, even if at member state level, it's more of a struggle?
At the European level.
A key priority.
Yeah. I think the key priority would be to really invest in prevention. And this is the case of Poland. The treatment is there and is accessible for everyone, but we don't really have the prevention strategies. And this is the biggest problem. So definitely prevention among vulnerable groups, but also general population.
Magdalena, thank you so much. Great to have you with us, and thank you for your insights, and maybe later on we can come back to that issue of inequalities of access and some of those struggles, how the EU level can help not only support member states who want to do more but don't know what to do, but also those member states that are lacking that political will. I am informed, reliably informed, so I'm going to keep my fingers crossed that we can now hear from UNAIDS, from Christine Stegling. Let's hear what she had to say.
This is UNAIDS.
Thank you for inviting me to speak. We appreciate the support of the HIV Outcomes Initiative and all others associated with and participating in this event. In light of World AIDS Day, it is wonderful you're having this event to highlight what we know can be done, ending AIDS as a public health threat by 2030, in the context of the UN Sustainable Development Goals. And we know that communities are critical to reach this goal. Our World AIDS Day report this year is entitled Let Communities Lead, and clearly spells out the evidence. Communities link prevention services to those most in need. They deliver life-saving treatment. And let's not forget, communities were also the ones who successfully challenged drug prices for life-saving medicines for ART, driving the price down from $10,000 per year per person to $70 per person per year. The path to ending AIDS as a public health threat is clear. It is articulated in the Global AIDS Strategy, which runs until 2026, and is reflected in the 2021 UN Political Declaration on Ending AIDS. We know this is the correct path because countries following it are seeing market progress, even countries where the burden of HIV is the heaviest. Whether or not all countries are willing to take this path to end AIDS is a political and a financial choice. This is the argument we made in our July report, that there is a real chance to end AIDS as a public health threat by 2030 if we follow the path that some countries have already taken. 5 countries have already achieved the 95, 95, 95 targets for HIV testing, treatment, and virus suppression at the national level. And 60 more are close to doing so. This is proof positive that we can, with sufficient political leadership and financial investment, reach our interim targets for HIV testing and prevention, and by doing so, eventually reach our goal. If we are to end AIDS, we must address the gaps in subpopulations and in geographies. Members of key populations, adolescent girls and young women, and children are being especially left behind. And often those most marginalized are also the poorest people, even if they do not reside in the poorest countries. No pandemic can end if it only ends in some places for some people. We cannot end AIDS unless we meaningfully address the inequalities that drive AIDS and other pandemics. We must protect the human and gender rights of all people so they can safely access life-saving HIV prevention and treatment services. And we must overcome the stigma, discrimination, and combat HIV-related criminalization, as all of those things push people away from life-saving care, endangering individual and public health. The work of UNAIDS is critical for reaching all in need of HIV prevention and treatment. By strategically steering the response, UNAIDS maximizes the return of all investment made on AIDS, including from PEPFAR and the Global Fund, ensuring the most lives are saved, most quickly, and costs are minimized. The Joint Program on AIDS is multi-sectoral, is present in over 100 countries, and we support and facilitate bigger multilateral investments. While we are laser focused on reaching the 2025 and 2030 goals, we are simultaneously strategizing about how to sustain the gains we made to date and those we intend to make by 2030, well beyond that threshold. Our success must be maintained even as the response to the pandemic evolves over time. In a post-2030 world, we will need to ensure that tens of millions of people living with HIV can affordably and equitably access life-saving antiretrovirals for the rest of their lives. And we will need to stay vigilant on the prevention front to ensure we don't slide backwards. A focus on a sustainable future for the AIDS response is neither a new concept or a veiled attempt to identify an exit strategy. Rather, it's an old concept whose time has come. We were always going to need to design a fresh approach to the AIDS pandemic once we emerged from the emergency response phase. Our upcoming evidence-based midterm review of progress against the 2025 targets will give us the data we need to understand how to build an HIV response for the future, capable of protecting the gains we have made. The key to our success lies in securing the political leadership. And 2024 is a critical election year in many European nations, at the national and at the regional level. Elections for the European Parliament and the nomination of the new European Commission will determine our ability to curtail the AIDS pandemic in Europe and beyond. UNAIDS is eager to work with the EU institutions to build on the current momentum so we end AIDS in Europe and across the world. Thank you for the work that you are all doing on this issue. We look forward to continuing to partner with you and to make what we know is possible a reality. I'm sad that I can't be with you in person today, but I wish you fruitful deliberations.
So, Christina Stegling there, underlining that crucial question. We talked about the progress we have made as well as the challenges that lie ahead. How do we build an HIV response that she, as she puts it, is capable of protecting the gains that we have made? And highlighting again that the European elections is a moment of truth, if I could put it that way, if we are to, as she put it, make what we know is possible a reality. So to discuss that and focus on some of the key areas that we need to address, we're going to turn now to our panel talking about advancing HIV care, a person-centered approach to long-term health and the health-related quality of life among people living with HIV. I'm delighted to welcome our speakers. Bring your nameplate with you if you, oh, she's going to grab them for you. Professor Oana Sandulescu from the Carol Davila University of Medicine and Pharmacy, National Institute for Infectious Diseases, Prof. Dr. Matei Balz in Bucharest, Romania. Oana, very great to have you with us. Mario Caschio, who is chair of the Quality of Life Programme at European AIDS Treatment Group and HIV Outcomes Steering Group member. Mario, fabulous to have you here. Do come and join me. Professor Jeffrey Lazarus, HIV Outcomes Co-Chair and Head of Health Systems Research Group, IS Global, at the Hospital Clinic in the University of Barcelona in Spain. Always lovely to have you with us, Jeffrey. And Professor Dr. Nicoletta Policek, who is Chair of UKCAB, the IHV Treatment Advocates Network. Great to have you with us too, Nicoletta. So what we're going to do here, I've asked our panel not to make opening statements. I've got a couple of questions for each of them as we focus on those 4 key areas that I mentioned at the start of the event that are highlighted in the HIV outcomes policy paper. And then hopefully we'll have time for some broader cross-cutting questions and also a few questions from you. But Oana, let me start with you, and perhaps we could start with this issue of stigma and discrimination, which has been underlined by so many of our opening speakers already, and what we need to do to improve it. And one issue that I know is very central to the HIV outcomes approach is this issue of patient-reported outcomes. Can you just explain how you see their role in addressing and in measuring health-related quality of life and ensuring indeed that not only do we have them, but we use them and that they're taken into account?
Thank you. I think this is a very important question to be asking and to be asking ourselves right now. So as a clinician, I can tell you that patient-reported outcomes are the main instrument that can actually tell us how our patient feels that he or she is doing. And we see data from countries that have already started implementing patient-reported outcomes and using them to discuss the perceived state of health by the patient. And we have fantastic data coming from Italy showing us exactly when and how they can implement it. And we do have the new EX guidelines that have highlighted the fact that patient-reported outcomes should be included into clinical practice, and that should be measured at least yearly in order to get a sense of what's going on and then what has been happening and what has been developing. So the main issue is how can we implement them in different countries, in different healthcare settings? How can we use them in order to be able to connect with your patient? How can you allocate more time in order to discuss these issues with your patient during your consultation? And we have some fantastic good practice models out there that I think we should try to look into more details. In order to see how those can be implemented in very different settings, because patients with HIV, they are being treated in different types of settings, different types of clinics, and they all need to have access to the same quality and the same information.
Just to understand, you talked about learning from those that are doing it. Just how widespread is this now? I mean, what's the scale of the challenge to make this something that happens across the board?
Well, it has started to be implemented, but the issue here is that we also need information in choosing the types of patient-reported outcomes that we measure. So in different settings, we might be measuring different things because every different clinic, every different setting has started to implement something at some sort of level, but what we're struggling to do right now is find what is the common ground.
So we need a more harmonized approach to it.
Exactly, more harmonized to provide comparable data from country to country, because we're not alone in this. We're actually all in this together, so we should find something that's comparable across settings.
And when we talk about one of the key issues, of course, here, because we're talking about people's perceptions, their own perceptions of their well-being and all those different dimensions. When we talk about mental health, which is an absolutely central part of this, what are the key challenges from your perspective that people living with HIV face, and what strategies really have we seen? What works best to address them? And going back to your point about we have some good practice models, are they replicable across the board, or do we need to adapt them and tailor them to particular circumstances?
Well, I think that in terms of mental health, it's not just our patients that we should be talking to, it's the whole general population, because I feel that we don't exactly understand that mental health is not the absence of mental illness. Mental health is so much more. Mental health is emotional well-being, social well-being, psychological well-being, and it's a term that encompasses so much more than we have previously thought that it did, and it's something that I think everyone should understand on different levels. And it's something that we should definitely be promoting more. It's something that we should focus on. And it's definitely a very relevant topic that hasn't been explored as much so far.
Maybe come back in our broader discussion to what impact the Commission's new communication on a comprehensive approach to mental health might make, but we'll come back. Thank you very much for now, Anna. Mario, just turning to the issue, an issue that the Commissioner mentioned, that of comorbidity prevention, treatment and management. When it comes to addressing this, we're talking about very complex needs. To how much of a problem at the moment is fragmentation? Because I know HIV outcomes emphasizes a lot, not only a person-centered approach, but an integrated, holistic approach. How much of a problem is fragmentation, and what do we know about what works to make healthcare systems take an integrated approach?
Well, thank you, Jackie, for the question. I think it's an important question. And yes, it is a very big problem when it comes to HIV care. I mean, in fact, but to have a better understanding of the impact that fragmentation of care has on health outcomes, but also on the sustainability of our healthcare systems, we need to look at the demographic changes which are occurring in this population, but also to the fact that people living with HIV are experiencing comorbidities at a higher rate than the general population, but also at a younger age. So there are many European studies, such as the Italian ICONA cohort or the Dutch Athena cohort, which estimate that by the year 2030, over 70% of people living with HIV will be aged over 50, with a great proportion of these over the age of 65. And with over 80% experiencing at least one comorbidity, and about 30% with 3 or 4 comorbidities. So as we can see here, the life expectancy of people living with HIV is approaching that of the general population. But this will probably result in less healthy years. There's a nice study which was published a few years ago, which indicates that still today there's a 16-year gap between comorbidity-free years between people living with HIV and the general population. So I would say that the burden of comorbidities and multimorbidities can further complicate, let's say, the complexity already of HIV care.
But given that, Mario, then, why are we struggling so much with this issue of fragmentation? And what is the key to moving from fragmentation to an integrated approach?
Well, I mean, people living with HIV will be increasingly needing additional healthcare services. So it will be, let's say, navigating the healthcare system from one medical specialty to another will be challenging for many. This is one thing, especially as you grow older. And what the elements I see in fragmentation of care today is a lack of shared medical records. There's poor communication between healthcare systems, healthcare services, and also a lack of coordination of care plans.
And in terms of successful models, things that we can learn from, because Oana also talked about countries where they are taking, we've seen with patient-reported outcomes, countries where it's working, and she mentioned Italy as one of those. Can you give any examples of successful initiatives, collaborations that really are addressing this issue? And the same question to you about replication. Is it very much dependent on your healthcare system and the way it is run, or can they be copy-pasted, if you like, across other countries?
Well, as Oana was mentioning, there are many examples, promising examples, that also respond to these issues I am talking about. And I would like to talk an example from Italy, from my country, of which I have personal experience of, which would be the metabolic clinic of Modena. Well, this metabolic clinic is active since 2003. It's run by Professor Giovanni Guaraldi, and it has adopted a person-centered and integrated and holistic approach. And all this is done through a multidisciplinary one-stop assessment. So this means that there's a multidisciplinary team formed of infectious ID doctors, of also, let's say, cardiologists, orthopedics, diabetologists, nutritionists, and so on, just to name a few. And together they evaluate a person's health, physical and cognitive health. And this, the combining at the same time clinical practice, but also educational interventions, which means like interventions regarding exercise or diet and things like that. So what happens is after this assessment and before going to the clinic, you fill in questionnaires, the ones that Oana just mentioned. You fill in these questionnaires, a series of questionnaires, and you also keep a diet of your food intake. So at the moment, after all the assessments which are done during the day, what happens is you get, when you go for your consultation, you get a clear picture of your nutritional deficits, you get a clear picture of your emotional deficits, and also of your physical deficits. This allows, let's say, a good open conversation, identifying critical areas of which, and do a joint priority setting and a joint decision-making on interventions.
But it all has to start there with that broad assessment of all these different aspects. Thank you very much, Mario. I hope we'll have time to come back on some of those issues in a little while. But Jeffrey Lazarus, always lovely to have you with us, Jeffrey. And one of the crucial issues here we're talking about is measurement and monitoring of health-related quality of life. Because as I understand it, I think something like in 2 or 3 years ago when this was looked at, only 5 out of 48 countries were even measuring health-related quality of life. Many don't measure comorbidities, many don't measure stigma and so on. It's not well monitored. What for you is the key to filling in those gaps and then making sure that the data that we do collect really is used for evidence-based policy making, for developing the sort of strategies Mario was talking about and Oana was talking about?
Well, this was an issue of 5 countries focused on health-related quality of life for people living with HIV. And what we've seen is that in other therapeutic areas, quality of life will be measured much more. So, so it's not, so there's a disparity between focusing on people living with HIV or looking at quality of life in other disease areas. And when we founded HIV Outcomes back in 2016, we were saying, in the EU, we need to set an example. As we're approaching the 390s in more and more countries, we need to think about what we called then a fourth 90. And a fourth 90 that went beyond viral suppression. And we said, well, what is it beyond viral suppression? And we said it's really about health-related quality of life, and we've broadened that to say it's hard to define sometimes HRQoL and quality of life to really just quality of life. And defining health, as Professor Owana said, thinking about physical, social, and mental issues. So not forgetting the social and mental well-being that WHO included in their definition, mind you, all the way back from 1948. So we started pushing the HIV outcomes partners and in our advocacy to measure health-related quality of life, focusing on the European Centers for Disease Control, who carry out the Dublin Declaration monitoring, to say, if you have to report on it, if you're measuring it, it will hopefully provoke you and push you to start measuring it. And consequently, if you're measuring it, we have a baseline to look at how to improve it. And this requires health system reforms. So we took a bit of a top-down approach, going to the governments and saying, you really need to address this issue. It's not enough just to achieve viral suppression for all the reasons we heard.
Let me follow up on that in a moment, but can I just ask, why is it measured much more in other disease areas? Why do you think there is so much less attention to it in this area?
So, well, I think we need to think about how quality of life is or health-related quality of life is measured, because it's often measured just focusing on drug interactions or treatment interactions. So I'm thinking here and we're thinking as HIV outcomes of a much broader measurement that brings in the social, mental.
So it's more challenging.
It's much more challenging because you have to listen to the patients. And I'm really pleased to have a clinical expert on the stage as well, because I mentioned the top-down approach, but the bottom-up approach is clinicians need to integrate this into their practices. That's almost the bottom-up approach. And that means also patients and patient advocates, people living with HIV, saying, we want to be heard. These are the symptoms, the signs, the issues that are affecting us that can affect our health.
Because it's all about their perception of their own well-being, if you're talking about that health-related quality of life. Just in terms, you lead an HIV outcomes subgroup that has been looking at how to deliver a better framework for reporting and assessing this. You talked about top-down approaches, and I wanted to ask you, as we are in the European Parliament, about what the EU can do to support member states, and that issue that was raised about standardizing a harmonized way of looking at this and measuring this and monitoring this. How do you see the EU's role, and what do you want from the people in this building and the policymakers in the Commission?
Well, I mean, what I'd like is for them to do what, Commissioner Pietikäinen said, which is amazing, to keep, HIV on the agenda. But to do that, like Mario said, we need to mainstream it. So we can't have, let's say, a more HIV exceptionalism. We need to note, as she did, that there are still thousands of people dying of AIDS. There are still thousands of new cases. So we're far from where we want to be. But at the same time, if we're going to keep this on the agenda, we need to be addressing it within, as was already mentioned, the different common comorbidities. We need to raise awareness that people living with HIV are more likely to acquire those comorbidities at an earlier age, because so many people started late because the guidelines were different then. And therefore, since they're in care and they're on antiretroviral therapy, we should be providing them with the full care that they deserve and that we actually can provide to them.
Thank you very much indeed. Lots to come back to in a moment. But Nicoletta, let me come to you last. And Mario gave some numbers there of the ageing of populations. The Commissioner underlined this as a key issue and the new needs that arise from it. What for you are the most important actions that we need to take to ensure that people who are ageing with HIV have the best possible quality of life? I know there was a thing called the Glasgow Manifesto, I think 2022. Yes, yeah. What sort of areas, what was that manifesto and what was it looking at?
I'll come back to the Glasgow Manifesto in a minute, but I'm just answering the first part of your question. I think it's important for me that we start changing the narratives, because so far we've been talking about aging population without making really a notice of the different populations that are aging. And I think for me it's important that specifically when we talk about women, because women are not just visiting the space, women are in the space. And it's fundamental that we don't talk about aging and ensuring healthy aging with HIV. And then we add, and by the way, we also talk about women and the menopause, because there is much more than the menopause and hormonal imbalances and issues around hormones for women, because otherwise it's a kind of very positivistic approach, positivistic in the sense that, Lombroso many years ago, many centuries ago, almost said that women's behaviors are linked to hormones. Consequently, that's what we are. And that's my first part of the question. The other point, before I get to the Glasgow Manifesto, very briefly, I just examined 182 papers which were related to ensuring healthy aging and quality of life, and 141 papers, so it's kind of, strengthening my point, didn't take gender into consideration. So there was a kind of assumption that male is the norm when we talk about healthy aging, which is very much still related to an aspiration, which is, in order to be healthy and aging well, you need to be able to exercise, have a variety of foods at your disposal, which is not the reality of most people actually living with HIV and aging with HIV. Briefly going to the Glasgow Manifesto, though I'll have much more to say on this issue in particular, I think what is important about the Glasgow Manifesto is a community-led ask to finally taking into consideration that people are living with HIV, but also aging with HIV. And the aging with HIV is such a broad spectrum of experiences in terms of comorbidities, as we already mentioned. There is the psychological spectrum that we need to explore further. There is also, we're also sexual beings, so sexuality is also very important. Mental health, it doesn't necessarily mean ill mental health, it's also opportunities to maintain good mental health. Indeed. And the Glasgow Manifesto is a way to really put on the agenda, and I'm referring now to the setting where we are, putting on the agenda that people are aging, and we can almost translate the Glasgow Manifesto into taking into consideration that people everywhere, in every single possible setting, are aging, and we need to have a age-friendly language with,
Absolutely.
ageism and discrimination.
And that crucial issue of equity, very much at the heart of that. And those, as you say, different groups, different needs, need to have stronger policies to address all those, to empower people. Just in terms of the same question really that I asked Mario, can you give any examples of initiatives that are really working and that can perhaps be replicated across the EU?
So my universe is very much UK based. So there are initiatives in the UK at clinical level where there are similar settings that the one that Mario describes, such as, for example, the Silver Clinic in Brighton, near London. But I think that for me, the most important initiative, which is in the making, is that a group of old and aging people living with HIV in Scotland got together to start reconstructing, fragmenting and reconstructing the local, as in Scotland-based agenda when it comes to aging well with HIV in terms of social and health care. And I think that's probably not only because I'm part of these movements, but also because it's community-led at every single level. Yeah. And that is what is very much fundamental for me. It's just that we're not kind of carving a space. We occupy central space, and we continue to do.
Thank you, because I wanted to ask you all, and I will come back to you in a minute, on the key ingredients if we're to have really effective strategies to deliver this integrated person-centered approach we've all talked about, and that clearly, that community level, absolutely key. But before I do that, and because we have limited time, I just wanted to see if there are any questions from anyone in our audience. Does anybody want to join in the discussion? You can see, you can either submit them at slido.com, or I suggest in the interest of time, raise a hand if you have something you burningly want to say. Okay, let me come back on this question of really, and I think each of you have begun to identify them, but Jeffrey, maybe I start with you this time. In terms of the really key ingredients, if we're going to get this collective issue, because what I'm hearing a lot, and the Commissioner said at the beginning, was about together. She kept using the togetherness word. What for you is the key to really working effectively together? And also in terms of what this question I keep asking about the EU level and what the EU level can do, because this is in the end a member state competence. It's a national government competence to do the things you're talking about, to run the healthcare systems and to do these things. How do you see the role of the EU in all of this?
Well, I mean, the Commission, the ECDC is a specialized agency of the Commission, and so is the European Monitoring Center on Drugs and Drug Addiction, which also addresses some infectious disease issues, including HIV. So at the Commission level, it's engaging, and they do, with the ECDC and the EMCDDA to work with their national focal points to keep this, really on the agenda. I liked what the Commissioner said about the EU Health Union. I think, when we were doing events like this before COVID, we spent a lot of time explaining what quality of life is and what health-related quality of life is. Now we're actually just talking about it. Everyone has experience now of reduced quality of life and health-related quality of life thanks to the pandemic. So we know what we're talking about, and we need to explain that there are some people who will have this for a longer time and for various reasons, and therefore we need to address it. So to answer your question, I think at the Commission level, there's work that can be done with the specialized agencies. I think the pronouncements of the Commissioner around the EU Health Union are important. I think parliamentary resolutions are important, but we also need to be realistic. Countries will do what they want to do for various reasons. So we have opportunities under various presidencies to bring people together, leaders together together with civil society. So when I say leaders, I mean from civil society to government leaders, including clinical association leaders, to have high and even low level meetings about how we're going to be able to change things. Because we need, again, that bottom up approach. There's a lot of, not a lot, but there are a handful of good examples in Italy, in Romania, in the UK, in Denmark, in Spain. So how do we make that the norm instead of trying to list all of those?
Just a thought there. Is there something we can say about why those countries are particularly good at this? Is it because of the priority they attach to it? Or is there something particular in those countries that makes a difference? Just very briefly before I move on.
Yeah, I mean, every country will have their story. I think fundamental to it is always the role of civil society, but also the role of leading clinicians. This will not happen without the clinicians either. And then sometimes we're lucky enough to have the right policymakers and decision makers who will actually
So it's when all those come together, that working together really works, it works.
It's not impossible, but there are many stakeholders involved.
Thank you. So, Nicoletta, in terms of those key ingredients for effective strategy, you talked about the community level and the involvement being so important. Is there anything else you would identify as being absolutely key to make this work? And do you have a particular ask in terms of the EU level in order to support national efforts in this area?
Yeah, I've got several particular asks, but I think that because people live with HIV don't live in a different parallel universe, but we have to tackle poverty. Consequently, at EU level, I suppose a legislation that tackles poverty directly or in a different way than what is currently doing. The same would be with violence against women and men as well. As they age, they're often victims of violence. So these are asks for me to the EU, because as well as what we have been saying, otherwise we seem to be refined to a container, but we do live and we do experience life as everybody else. So by tackling general issues, then we can also improve our quality of life.
Thank you very much indeed. Oana, same question to you, but two very specific things have come in on Slido, which I just wanted to throw at you. In using PROM, what are the data to show that it improved communication between PL HIV? I'm not sure what that acronym stands for, but I'm sure you know. Sorry? People living. Oh, it's very obvious when you know, isn't it?
But we've also been asked not to use that abbreviation for those reasons.
Yeah, I'm going to say, so what is the data to show that it did work, if it worked, between people living with HIV and HCPs and genuinely improved health-related quality of life? Are there controlled trials that show the difference when you use them, when you don't, I think is the question.
Well, I think that it's really important to look at the data that actually coming from Professor Giovanni Guaraldi that Mario also mentioned, because that is one of the first clinics that implemented prompts. And Professor Guaraldi was also open enough to come and travel to different countries. He traveled to Romania, for example, and to share his experience in working with that. And I think that as we are starting to implement them, we're going to see more and more data. So the data that we have right now are for different questionnaires that you apply. And you can find the data for each different questionnaire. It was applied and how did it impact specific outcomes? How did it impact the patient's perception, the communication with the healthcare worker, or how did it change from one visit to the next? That's the data that we have, but the data that we need, and this is really important, is the data coming from clinical practice, coming from the actual implementation and the actual discussion that we have on a day-to-day basis with our patients.
Thank you very much. And in terms of this question of the EU level and the key ingredients for a strategy, just throw in, this is a comment, not a question so much, but it's a suggestion. Why not run an EU-wide PrEP program or needle syringe exchange programs to aid stimulate national policies? So an idea there. But for you, what do you want to see from the EU level in order to support member states in addressing precisely the sort of challenges we've been discussing?
So since we have been talking about stigma, about self-stigma and structural stigma, I think it's really important that what we plan to do in the next months to years is to normalize HIV. It should be as simple for someone living with HIV to say that I have HIV as it is for someone to say I have a hypertension.
Yeah.
This is what we are targeting. And I think that in order to reach this, we should be able to bring HIV in the discussion, to keep HIV as a priority and to be aware of this. And something that we haven't really had time to touch upon in this discussion is HIV testing. Because yes, we're talking about doing fantastic things about improving access to treatment, improving treatment efficacy, and improving healthcare related quality of life beyond viral suppression. But in order to meet all of these steps in the HIV care cascade, we need to diagnose.
Yeah.
We need to diagnose the undiagnosed fraction. And in order to do that, we need one, to normalize HIV. It should be normal to go and get an HIV test, the same as I go and get a blood count test, for example. And what we should be looking at in terms of differences from country to country, each country has its own health system, has its own testing policy. So I think something that we should be looking at coherently is testing strategies from country to country, and how can we open those up? How can we make testing part of routine care?
Thank you very much. I want to come back on the issue of stigma in the moment because there is a specific question from our audience to it. But Mario, for you, key ingredients of effective strategies and the role of the EU.
Well, the role of the EU, for example, I think what the commissioner was talking about, the expert group of non-communicable diseases, which now has included communicable diseases. Well, we need to make the best of use of this tool, for example, because when I talk about the burden of comorbidity and multimorbidity, this can be a very important tool, which can, let's say, combine the two, communicable and non-communicable diseases, something that was missing. In fact, we advocated a lot to have communicable diseases included within this expert group. And I think there that we can do a lot of pilot projects or whatever. When you talk about dissemination, replication of best practices, it's not only about making, highlighting them, disseminating them. It's also about this. My personal opinion is that also facilitating, for example, visits of nurses and doctors, for example, to these centers of excellence. Because as we were saying, I mean, each healthcare system within Europe is very different, one from the other. Even within countries, it can be very different. So knowing how things can be adopted or replicated, you have to be on the spot and see
So
them.
that's interesting, because one of our audience saying, how can the EU support HIV clinics specifically in this integrated approach that you're talking about, all these different aspects, and avoid this fragmentation? You're saying, actually, really it's that exchange of best practice, showing what can be done, and then learning from that how you adapt that to your own That for you is the
environment,
key.
own context, yeah.
Yeah. Just on this question of stigma, something both commissioners talked about earlier on. Nobody has mentioned, interesting in talking about the role of the EU, nobody's mentioned the June communication on a comprehensive approach to mental health and whether you think that can be used, whether that is part of the equation here. But I'm just, in terms of stigma, the question from our audience again is how can stigma be addressed at the European level? It also asks about the impact. I mean, the commissioner spoke earlier about how it means people don't necessarily use public, don't get tested. I think she mentioned that, may reduce their taking adherence to medical treatment. It can, they're reluctant to come forward. I mean, and discrimination and stigma, I was very shocked to read some of the figures you give about health workers. This is a problem of professionals. So what can the EU do, and is it doing enough? I think there are some guidelines, ECDC guidelines, to help with these sorts of issues. How can the EU help to address this issue? Anybody who would like to come in on that? Jeffrey, please.
Sure. I mean, we've been saying here at HIV Outcomes, along with our members, that stigma and discrimination go hand in hand, but they're not the same thing. Often we've focused on discrimination because their governments, including the EU, can establish regulations and actually prosecute people who discriminate based on HIV status or various other issues. The commissioner mentioned there was stigma, and then there was actually the fear of stigma, which is like another step away, but also a reality with the same kinds of outcomes of reduced health-seeking behavior, less adherence, poorer health outcomes. So, and when we look at stigma and we break it down, we also see that there's stigma among healthcare or stigma and discrimination among healthcare providers. So I think, for governments, it's about enforcing their discrimination regulations, which in most countries, and I'm not a lawyer, are now quite strong. But then in stigma, to address stigma, I think it's about, opening up the discussion around it. Like you said, making it as easy to say you have HIV as you have hypertension or anything else. So when the commissioner sits here and tells us her story of having worked with groups, people living with HIV, 25, 30 years ago, being willing to be here today, this is very different than, I think we have some people, some leaders and some governments who would not sit at the table with people living with HIV and talk about stigma and discrimination. So I think at the high level, one of the best ways to address stigma is to have high-level officials speak out against it.
Yes.
If I can add something to this, we must also consider, when we consider mental health and stigma, they are closely connected, very closely connected, stigma, discrimination, and mental health, especially self-stigma, for example, when we're talking about the difficulties also in getting tested and retention and care and so on. And so I think addressing mental health in the integration of mental health services in HIV care can be an effective way of combating stigma as well, for example, because it gives the opportunity of understanding those needs, those mental health needs of people, which are directly connected to their feelings of, let's say, of self-stigma or fear of stigma or whatever.
Thank you, Nicola.
Yeah, I agree with every single word has been said so far, but I think for me it's important also to start dismantling stigma, to have a very inclusive language that doesn't discriminate, and we still use too often a language that is excluding some people, upsetting some people because of their behavior, because of where they come from, because they're not national of that specific country. So I think that, when it then translates into retention, care, adherence to medication, I think that the way in which we even describe those who are living with HIV is a very small beginning to start a much bigger project, which has to be also ongoing, because I feel that very often we talk about stigma, we talk, as Jeff said, that discrimination is easily understood because it's within a legal context, and there are ways in which we can tackle this. But then we leave stigma as it is, and we move on something else, which is an ongoing conversation to have.
Absolutely. Quick one, if you would.
Really quick, just to follow up on what you asked, is there something that's being done where, yeah, there is a very important initiative that's actually going on led by the ECDC and the EX, there's a stigma survey to measure stigma across healthcare settings and across all types of healthcare workers that are involved in the care of people who might or might not be living with HIV. And the survey is actually open until the 30th of November, end of day. And I would encourage everyone who's working in the healthcare system to complete it, because we need to hear from everyone. Because the first step that we need to understand is to understand where stigma is, and then to move a step forward and to see what is the reason behind stigma. Because if it is a lack of understanding on how it can be transmitted or different perceived risks by healthcare workers, these we can address because we have information that we can give to address these issues. So it's really important to understand where stigma is to be able to then implement steps to reduce stigma.
Thank you very much indeed. We are almost out of time in this session, but I wanted to end by coming back to something the Commissioner spoke about in her opening intervention when she said we need to make sure that this remains a priority. And indeed, our speaker from UNAIDS also talking about how do we make sure that we protect what we have gained and we don't slip back again. So for each of you, as we approach, and I'll start with you this time, Mario, and go down the line, as we approach a year of European elections, of a new Commission, there is a concern raised by somebody in our audience saying, yeah, this might be a moment of opportunity to build momentum and put new impetus in, but also a concern could be with increasing support for far-right parties, and therefore, you know, the question she's asking is, could there be pressure on prevention projects because they tackle those, they address those vulnerable groups? What for you is the key to keeping this where it needs to be and really making sure that we make progress to replicate the countries that have done so well? Mario, for each of you, 1 minute or so each, if you would.
Well, I think we have to make the case if we want to keep, of why we want to keep HIV as a priority on the political agenda. So we have to, for example, we have to make the case, as I discussed before, of this changing of scenario we have today, and so of the need there is to, let's say, readapt our response to the HIV, both in prevention and also in care, for example. So it's not going beyond, like our initiative says, going on also beyond viral suppression. So we have to, there are the changing, the needs are changing, and we have to adapt to these changes.
Thank you very much indeed. Oana.
So I think that as a final thought, another issue that we should focus on is access. Is there access at every level? Access to everyone, access to testing, then access and linkage to care, access to treatment, because that's another of the priorities that has been mentioned, and then access to monitoring and access to this kind of measuring healthcare quality, healthcare-related quality of life, and then access to interventions to keep your mental health, to keep your health-related quality of life, and to improve it if there is, of course, room for improvement. So I would just finish up in saying that we need to ensure that we have access on every level for everyone.
Thank you very much. Nicoletta.
I would say let communities lead. Because when we have communities involved at the very beginning, then we know what priorities are. So rather than being sitting at the table when there are other stakeholders, we can and we have a different sort of small seat at the table. We should be able at the very beginning to start a conversation because we know what the needs are of our communities.
Thank you very much indeed. Jeffrey, you have the last word. And then just to warn our wonderful team who are supporting us technically, MEP Cerdas is running a bit late, so I'd like to go to the video before we go to the MEP. So if you could be ready for that. Jeffrey.
Thanks, Jackie. I think if we're going to keep HIV and AIDS high on the agenda, we need to remember that there'll be a new commission for 2024 to 2029. We have 2030 goals. So I think this is about insisting that they honor their commitments that they signed to end HIV and AIDS at the World Health Assembly with the new Global Health Sector Strategy on HIV, sexually transmitted infections, and viral hepatitis, in agreeing to the UNAIDS strategy and in various other places. So governments have made commitments. Now we have a commission that needs to implement it. And I wouldn't want to be, known as the commissioner who at the end of 2029 failed to meet the 2030 goals. So civil society should lead. Yeah, you should lead in insisting that the politicians and the commissioners honor their commitments to ending HIV.
And do you share the Commissioner's concern, just to follow up, Jeffrey, that we could fall back, that there is a risk that we could not only not build on what we've done, but we could, if we don't remind them of those commitments, we could go backwards?
Well, we already fell back during COVID-19.
Yeah.
And we've seen in new surveys that we're not particularly prepared if a new pandemic comes out. So, so I think, you know, we may fall back, but one of the ways to not do that is to mainstream addressing HIV and AIDS in all of the work of common comorbidities, be it metabolic dysfunction associated steatotic liver disease, be it cardiovascular disease, be it other common comorbidities, and talk about the integral health of people living with HIV and not just HIV.
Thank you very much. Ladies and gentlemen, would you join me in thanking all our panel for a wonderful discussion? I wish we had twice as long. So many issues to talk about, but thank you very much indeed to all of you. I see that MEP Cerdas has now joined us, so we're going to, if it's all right with her, I can show the video and then come to you if you want a moment to catch your breath. Let us first hear from Sirpa Pietikäinen MEP. Again, she couldn't be with us today, but she very much wanted to address you. So let's hear what she has to say, and then I'll give the floor to Sara Cerdas. Please.
HIV and AIDS are still with us, but we have gone a long way from the dreadful early times when we did not know properly the causes, we didn't know the cure, and the stigma against the people with the infection were enormous and horrible. I would call it a crime, a human crime against human rights. So we have developed testing, we have developed prevention, we have developed very effective medication, and nowadays people with HIV can live very balanced and good lives as long as they companions without the infection. So clearly this is one of the big successes of human medical and health history. But still there's a lot to do. We have not won the infection yet. We need to fight against HIV and AIDS, especially in many developing countries, among people having sex tourism, among people that still are a bit careless about prevention in the casual sex relations. We need to understand how important it is to test oneself and test the risk groups quite often, but do it discreetly and give people the possibility to save their faces and to get tested without that kind of a big stigma hanging over them. And this is important because of the spreading of the disease, but it is important because of the human beings themselves to get the effective medication in place as soon as possible. Yes, we have to take care of the people and their health. We need to put efforts on prevention. We should not forget that it is still a serious disease. But foremost, we still need to fight against the stigma. We need to support, praise, and embrace the infected people. We need to have zero tolerance for any naming and shaming and negative attitudes and false information. This we have done with other diseases already. And this, yes, we can do it with HIV and AIDS also.
Sirpa Pietikäinen there, ladies and gentlemen. So, Sara, it is great to have you with us. Thank you for your support, the support that you give to these events and to HIV outcomes. Sara, we've been talking a lot about the needs, the new needs that come from HIV becoming a chronic disease, the needs of people living with HIV, and crucially focusing on health-related quality of life. And we've talked also about this moment of political opportunity, but also peril. Opportunity to advance, but peril that it may. The Commissioner talked earlier about the risk that if you don't keep the pressure up, it could fall back. We could lose them, it would falls down the priority agenda, and we could lose some of the gains we've made. So it is great to have you with us, and over to you.
Thank you, Jackie. Good afternoon, everyone. Always a pleasure to be here and speak in this event. And apologies for not being here since the beginning, but also the committee's work take a huge toll also in our day-to-day lives, but I wouldn't want to miss this opportunity to convey some of the works. I truly believe what the Commissioner said. I wasn't here, but it is to be true. If we don't keep pushing the buttons will disappear. And that cannot happen when we are going through the 5th decade of this pandemic. And this is something that needs our collective attention and action. I already shared in a previous event today on HIV also about some of the statistics that really struck me when the ECDC presented its report on HIV stigma. And a lot of fear is by people, 56% are fear of being stigmatized by health professionals, people living with HIV, to go to a health service. And that cannot happen in our day-to-day life. And I would also like to reflect on the importance of confidentiality, on building safe environments for everyone to have the care they need. And I would also like to connect that with what we are doing here in the Parliament. We have, for instance, the European Health Data Space that we are building, and the main one of our main priorities is to guarantee the confidentiality and security of our data. It's our most sensitive data, and we don't want. And in this report, we managed to get the opportunity for the patient that is the holder of the data to choose who they want to access or not. And I think this is also very important. We need to picture a world where this virus exists, but is no longer transmissible. And I think that can be achieved, but we need to focus or give higher attention to the 2030 Sustainable Development Goals. What we have at the moment is with the biggest pandemic in the last 100 years, 2 wars in our garden of if EU is a house, has shifted the intention, and we cannot lose momentum. And let me just say, when it comes to HIV, when it comes to other communicable diseases, momentum has been slowing down. A lot of focus on cancer, a lot of focus on NCDs, mental health, and rightly so, but we cannot forget also HIV, but also other communicable diseases that we still need to bridge the gap, such as tuberculosis, malaria, other neglected diseases, and hepatitis. In regards to European countries that have initially implemented very effective policies, and that includes scaling up HIV prevention, drugs education. However, the pandemic has disrupted that momentum, and there has been this alarming decline on newly diagnosed infections, and we need to go after those late diagnoses, because that can have a serious effect in the quality of life of these people. So I also truly believe that we have something to say when it comes to global health. This is not a fight that member state can face alone or the EU can face alone, and we have a duty also to work together with third countries in order to reach better health and a person-centered approach when it comes to people living with HIV. I understand that now we're going to elections next year, but I would like to finish with a message to state that I do not know how this parliament will look next legislature, next term. But I think it's important that we do not lose momentum when it comes to talking about HIV and towards ending HIV in Europe, and also put that in the agenda. Now that the campaigns are starting, put that in the agenda and put that up in the discussions, in the different forums. So your representatives and those that are going for elections are aware that this is something that needs to be discussed and more action needs to be taken. So once again, I don't know if I ran over my time, but thank you very much for having me here, and it's really incredible that we manage to gather ourselves every year here and discuss what are the up and coming challenges and what can we do more.
Thank you very much for ending on an uplifting note, but also a challenging note, that call to action. And it is, you know, the sort of work, the commitment, the support that MEPs like yourself, like Sirpa, and like Frédérique give to this initiative that makes such a difference. And indeed, the support that all of you and the work that all of you do. So it only remains for me to thank again all our wonderful speakers today. Thank you to our MEPs for supporting this event and co-hosting it along with HIV Outcomes. Thank you to the wonderful team, Secretariat behind HIV Outcomes, who make all of this possible. But most of all, thank you to all of you for coming. Thank you for your questions and comments. Sorry I couldn't squeeze all of them in. I managed a few, but it only remains for me to wish you a very pleasant rest of the day. Thank you very much indeed.